Well, I looked at the curriculum. There wasn't much with peds. I thought peds is a good topic for emergency personnel because I think it's something that we're all uneasy with, especially the really little kids. And the more I got into it, I realized that ALTE, an apparent life-threatening event, isn't a diagnosis at all. It's a chief complaint. And for the purposes of studying it, they've classified it and defined it so that we can do studies best how to evaluate it, because it's one of those things that we're all uneasy with when we come upon a mom who's got a child who looks apparently fine, that she describes this horrific situation that just happened, and here's the baby, and you're looking, baby looks fine, mom looks like she's been through World War III, and the whole family's upset, and you're trying to understand exactly what happened. And then the question is, was it an apparent life-threatening event? Well, what is an apparent life-threatening event? Let's start with the first case. And the reason I go to the case is because I want you to think about these cases as we go through the educational process and see how these facts play into your ultimate decision making. So mother brings 6-month-old to ED. While crying, turned red, spit up milk while breastfeeding, stopped breathing 5 to 10 seconds. When he turned red, patted child on back and he behaved normally again. Doesn't say she's a first-time mom, but it's in there between the lines. Let me get my little arrow over there. Okay. Here's the second case, a little bit more concerning by history. 6-week-old infant brought into the ED by EMS. While sleeping in mother's arms, she felt the infant go limp. Noticed that she turned blue around her mouth. Mom rubbed the infant's back, tried to rouse with response after 10 seconds. When EMS arrived, patient was awake, alert, with normal exam. So, in 2004, they did a study, and they took a bunch of paramedics, a whole bunch, and they trained them on how to recognize a ALTE, and then they followed the results to see. And they came to the conclusion after the end of the study that it was very important that the paramedics be able to recognize the ALTE, and it was also very difficult at the point of care to tell exactly how significant what had happened before the paramedics had gotten there was. So I'm here to give you a couple high points that you want to just have in the back of your mind, that when you hear, oh, this case may not just be an innocuous case. Yeah, you're going to transport and you're probably going to check the blood sugar, but this one may be one that we're a little bit more concerned about. Upon arrival to the ED, the infant was placed, case number 2, infant was placed on the monitor, appears stable, vital signs and exam normal. Mom denies recent fever or URI symptoms. Same event occurred a week ago while infant was sleeping, but returned back to baseline in 10 seconds, but did not seek medical care at that time. Born at 35 weeks gestation, delivered vaginally without complications, formula fed, growing well. So there's a difference between the two cases as far as the red flags. And anybody have any ideas what the differences may be, what the red flags might be that you'd be worried about in these two cases? Let me go back to the first one and see if you guys probably don't have an attention span much longer than mine. This one's got congestion, runny nose, no fever, born term, no comps, vital signs are normal, infant appears well in both scenarios. 2 days, 6 months. This case, 6 weeks. Felt the baby go limp. Couldn't bring the baby around in 10 seconds. Took a little bit. Still, the baby looked fine when EMS got there. Same event occurred a week ago. So it's a repeat ALTE. Born at 35 weeks. Formula fed doesn't mean anything. Growing well does mean something, but not in this case. This is case 3. These are my 2 little guys. My little ALTE's in blue there, the little guy. We'll get to him if we have time. He was very nerve-wracking when we brought him into my ER. Does the patient meet the criteria for an ALTE? What kind of workup does the patient need, if any? Does the patient need to be observed in the hospital, or can he safely be discharged home with follow-up? These are tough questions. These are questions that the ER docs have to make, and they're very uncomfortable with the decision because an ALTE is so loosely defined that it's difficult to put them all in one basket and say, oh, this kid's different than this kid. They're not easily separated. Why? Because, as I said, child appears well, looks fine now. What really happened? An acute, unexpected episode that is frightening to the caretaker. Now, some caretakers are more easily frightened than others. That includes at least one of the following: apnea, central or obstructive. Central being baby just stops breathing because the brain tells them to stop breathing. Or obstructive, stops breathing because there's something in the airway. Color change, change in muscle tone, choking or gagging. Clearly a broad definition of a chief complaint. Again, not a diagnosis, but a chief complaint. So this is what an ALTE is. American Academy of Pediatrics is still trying to bring a better definition to the table so they can better study it. They haven't had much luck as to late, but the guidelines are coming out. 0.05 to 1% in the population-based study. So why do we really care? It's only a 1% disease. Well, if your squad covers 100 million patients, 100 million people, or 100,000 patients, that's 1% is something you're going to see. Peak incidence is in the first 2 months of life. 80% of the ALTE episodes occur between 8 a.m. and 8 p.m. Okay, so these things are those 2 last points separated from SIDS, which is sudden infant death syndrome, because the peak incidence is different, and the ALTE and SIDS often occur at night, peak at night. Etiology: 50% of the time, a cause can be determined with a careful history, physical, and appropriate laboratory evaluation. Most commonly, the 3 big ones are gastroesophageal reflux, neurologic disorders, and respiratory infections. Now, how many of you in here have children? Okay. How many of you have children that have spit up and throw up? Okay. So gastroesophageal reflux is almost normal. We expect it. So where does that fit in the definition? It fits because even though the kids are refluxing, and even though their compatriots are refluxing, the kids with ALTE that are refluxing need to be worked up too, because a lot of them have a more significant reflux, or the reflux is tied to another more dangerous underlying problem. In other words, don't just say, the kid's spitting up, that's what kids do, don't worry about it. That's our first inclination, especially you get a first-time mom. She says, oh, you know, I've never seen this before. What do we do with this? So you say, oh, everything's fine, you send them home. No, you have to ask the questions. And you have to do the physical exam. So I was trying to, as I was going through this in my mind, I was thinking to myself, so if you if you called me on the phone, I'm trying to give command, your phone call to me would be, hey, you know, I have a patient, 2 days of age, mom, infant appears well, vital signs are all normal. Mom gives a history of the baby getting limp, changing color. That would probably prompt you to not even call me and just bring the kid. Or it could be, gee, you got there, everything looked fine. Mom said the kid spit up a little bit, turned red, then seemed to not respond for a couple seconds, but then was fine. Gee, you know, mom's refusing. And I'm saying to myself, well, wow, you know, if I'm given command and someone calls me with this, how am I going to handle that? Because, I mean, somebody can refuse for themselves, but can they refuse for their child? Okay? And what if this is not the first 3 things that it could be? What if it's not the gastroesophageal reflux? What if it's not the neurologic problem or the virus? What if it's abuse, which is number 4? And I just let him refuse. Etiology. Under respiratory infections, 20% of ALTE cases are due to respiratory infections, RSV, pertussis, whooping cough. Again, maybe not pertussis as frequently, but we do see a lot of RSV. They're still trying to figure it out. The respiratory infections, for reasons we don't completely understand, not only cause an obstructive apnea at times, but they can cause a central, where they develop an apnea that prevents them getting the signal to breathe. Let's see, what did I do wrong? All right. Neurologic disorders. By far and away, the most common neurologic disorder would be a seizure. So if you came upon an infant that wasn't looking fine, but appeared to be seizing, as a medic, what's one of the first things you want to do? Seizing child, seizing anybody. Maybe a blood sugar, okay? Back in the day, before we had ECT, we used to give people insulin to drop their blood sugar so fast that they'd have a seizure, because that was kind of like a reset, and it helped with depression. We've come a long way, but it still underlines the point that hypoglycemia is one of the most common causes of seizure. So if you see a seizure, think of that. Think your blood sugar, check that. Just like if you have a stroke patient, you want to check that because they mimic a stroke. Now, the tricky thing about kids is, and that's a separate lecture, seizure disorders, but in neonates, especially because the brain is not as organized and developed, when they have a seizure, the seizure may be as simple as a loss of tone. There will not, especially in the first couple days of life, be the jerking and shaking that you're used to seeing. It just doesn't happen. The brain's not organized enough. It's often very subtle. And it can be as simple as if you look at their extremities, you may just see their fingers doing this. And that may be a seizure. Or it could be the blink. Or it could start in the hand and then move in the arm and march. So seizures are very hard to pick up because in neonates, because the CNS is not as developed. This goes on to other causes, hydrocephalus, and it talks about ventricular hemorrhage. Ventricular hemorrhage is more of a problem in premature kids. They get germinal matrix bleeds. You see that a lot of this stuff that I'm talking about would become manifest early on in the child's age, in the child's growth. So that's why we have a higher index of suspicion for the kids that are younger, that are less than the 2 months. Child abuse is reported in up to 11% of well-appearing infants. Beware of the patient with a recurrent ALTE, with negative workup and recurrent resuscitation with a single caretaker. Abuse with results in head injury can present as an ALTE. So this is a little bit double-edged. Believe it or not, when they did the studies for people, when they tried to study the characteristics of the ALTEs that were due to head injuries, due to abuse, one of the things that struck me was one of the flags, if the parents call EMS with the first episode, those seem to be the ones that was one of the red flags for abuse. I'm not sure what the reasoning was. Maybe I don't know, but that was one of the red flags. You notice with the second case that I went over, it was a recurrent ALTE, but mom didn't call the first time. Driven by history and physical examination. In 2004, a study including prospective training of paramedics summoned to evaluate distressed infants illustrated the importance of early ALTE recognition. So that study kind of was what determined that, you got to go to the pre-hospital people, let them know what an ALTE is, and have them be aware of it. So you're looking for that limp, you're looking for the change in tone, you're looking for the change in color, you're looking for the choking, you're looking for the apnea. Tests ordered by history. Tests ordered in selected patients depending on the finding. So why did we do all this? Well, ALTE, what happens when a physician is given a case of a patient that's very well appearing, but they're concerned that something else may be going on? What do? Unfortunately, what they've done in the past with ALTEs is a whole bunch of tests. They're sticking needles here, putting the EEGs on, doing gastroesophageal reflux studies, not to mention, the ABGs, the CSF testing, the catheterization for the urine, all these things. And what they found is, unless the history and physical exam meticulously taken by the clinician at that point in time drives you to do one of the tests, it's very low yield. And all you do is you end up with an upset mother and a bunch of negative tests that haven't come to the correct diagnosis as to why it goes for the ALTE. Historical points. Now, history taking is the difference. Being able to take a good history is the difference between an experienced clinician, experienced individual, and knowing what they're hearing as important versus someone who's not. And when I was teaching, I used to teach family practice residents all the time, and I'd say to them, the difference between you and me is that I know how to ask questions differently, and I know how to get the answers I need, and I know then it fits different in my computer. But the difference is really in the history taking, like asking the right question, and knowing when to shut up and listen to the patient tell you. I mean, if you really don't know what's going on with a patient and you sit there long enough, they'll eventually spill as to what happened. They'll tell you, oh, I didn't think it was important at the time, but the kid got blue and went limp, but I thought he was kind of, I didn't know what to make of it, so I didn't mention it. Historical points. What activity? One of the ways I take a history is, and I teach to take a history is, I made a mnemonic. There's all kinds of mnemonics, but I use ABCD ROTS. I don't know why I picked that, but that's what I do. So activity. What was the infant doing at the time? Was the infant being fed? Was the infant crying? Was the infant sleeping? What position was the baby in? What did you do to make the baby better or worse? Did the baby seem to get better when you pick him up, or did the baby seem to get worse? Did you pat him on the back? Did you shake him? Okay, that's the one that scares me too, because here you have a well-intentioned parent who panics because the kid's having a seizure and they start shaking the kid. Now, that patient, that parent who's well-intentioned, although not well-informed and educated, gives you a child that you look in the back of the eyes and you see a retinal hemorrhage. Oh, this baby's been shaken. You abuse the child. There's a difference in that scenario versus the mother or the caretaker or the boyfriend who's watching the kid, who wants to make the kid shut up because he's crying all night and shakes him until he stops. Two different scenarios, same result. Character. Now, is the kid turned blue? Was the blue just around his lips? Was it head to toe? Did the kid turn red? Did he turn white? Any change in color fits the ALTE. How long did it last? Well, if it goes on for an extended period of time, I mean, if this is not just a momentary couple of second type thing, then that certainly is more of a concern, that the airway was really obstructed, or that the kid was seizing and it wasn't recognized, or the blood sugar was really low for a prolonged period of time, or that this is a more significant infection than we realized. A lot of these kids, when they are worked up, they find out that they have pneumonias and they have other things that on physical exam, when you first look at the kid, are not evident just looking like this, but when you start listening and you do a pulse ox on them, things become more obvious. You know, medicine's tricky. 40% of the time you can listen to a chest and not hear a pneumonia that's there, in the best of years. Onset. Did this come on quickly, or did it slowly evolve? How was this treated before? Last time the kid did this, what did you do? Well, I brought him to the ER, and they did an EEG, and they did a CAT scan, and they did a spinal tap, and it was all negative. Last time I brought him to the ER, and the doctor said, well, I'm a first-time mom, and said that don't worry about it, and just took the baby home. So how was it treated before? Yeah, I'm supposed to be giving the kid this medication. It's Depakine, and I missed a couple doses. I mean, the history of treated before can be very helpful. Severity. Did the kid get a little limp, or was he like a rag doll? I mean, did the kid seem a little confused, or was he just looking off into space for 2 minutes, which could be an absence seizure? One of the cruelest things I'd seen done, I thought it was cruel, was when I was doing my pediatric rounds. The pediatrician that was teaching me was also a pediatric neurologist, and he said, this child has a seizure disorder, and I want you guys to see what an absence seizure looks like. He took the pen light and flashed it in the kid's eyes with enough frequency, with the correct frequency, to bring on the seizure. The child just went like this. And that was the absence seizure. So kids are different with their seizures. It's not a seizure talk, but it is one of the important causes of an ALTE. Activity, was the infant sleeping, crying, eating? We covered that. Vigorous, gentle stimulation. Did you try and do CPR? Is that why the ribs are broken? Did you try and change his sleeping positions? Did you thicken his feeds because the pediatrician told you to? So the character. What were the respirations like? What was the muscle tone like? Were the eyes closed, blinking, or rolling? Now, sometimes if someone's seizing and you pull their eyelids back, you can see in the nystagmus off to one side. That's very helpful to tell you that the patient's seizing. Sometimes, if they've been seizing for a long period of time and they've used up all their adenosine triphosphate, or most of it, most of the body's energy is gone, they don't have this anymore because they're hypoxic and they've exhausted all their glucose and all that other kind of, but you pull the eyes back, and the eyes are still going deep, 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 deep. And that's like, ooh, okay, I got status epilepticus here, and I was going to just assume that the kid or the individual was postictal. And when the seizure goes on, unchecked, that's when the damage goes on. Okay, because your brain is trying to function, and it doesn't have everything it needs. And your brain needs oxygen, and it needs glucose. And if those things aren't available and you keep trying to push it, that's when cells die. Damage is done. How long did it last? Radiation. Did it seem to begin in one place and the other? Like I said, that you can get a seizure that starts in one place and moves to the other. Or did the belly start like this? Did you see the belly start to move and then all of a sudden the kid threw up and then had the ALTE? Was it abrupt, gradual, building in frequency or intensity? Treatments. How am I doing time-wise? 26 minutes. Okay. In the past, studies were performed. In the present, when you're talking about treatments, what was done in the past? What studies were done? What did you try to do to the infant to get them better? What present treatment? Are you giving them a cough medication that could be making the situation worse? And that's not uncommon. Were previous things tried, like prone positioning, thickening of the foods? Severity, we went over that. If a history and physical fails to suggest an underlying diagnosis, routine testing is unlikely to be helpful. Targeting testing may be warranted in patients with. So, kid looks fine. You didn't find anything on the history and physical. So now what? Do you plunge ahead? And these are the kids in those first two cases, the difference between the first two cases. Is there a history of prematurity? Were there multiple ALTEs? When I say multiple, I mean more than one, not just more than one in 24 hours, but more than one at all. Certainly one more in the first 24 hours, two in the first 24 hours is worse than two over a week, but still more than one ALTE. Child, is there a suspicion of maltreatment? Now, this is where you guys have like this huge advantage because you're walking into the house. And as a guy who used to be in family practice and used to do house calls all the time, you gain so much insight into what's going on when you walk into someone's house. Is smoke in the air? Is the whole place disheveled? Is it well lit? What's the caretaker look like? Are there drugs being done? What's the crib situation look like? Is the kid stuck in a drawer as a crib? I mean, these are things that I don't know because I'm at the hospital. But when you walk into a home, if your eyes are open and you're absorbing all these things instead of focusing right in on the patient, you'll begin to pick up a lot more. So just be aware of those things, and please, communicate them to the physician or clinician whenever you get there, even if they act like they don't want to hear it. Because sometimes it seems like you're annoying these people that are trying to do something else, and your history is so important, and they may not recognize it, but you need to recognize it. And you need to get it out. Multiple ALTEs, child maltreatment suspicion, suspected seizures, comorbid conditions. So this is the group where you probably would be likely to admit, or at least admit and observe versus send home. And these would be the ones that you would go on to do further testing on. Suspected seizures, comorbid conditions. So you think, gee, doc, when I was at your lecture a month ago. This is stuff I dream about. You know, guys can actually make a difference in somebody, and it makes a difference in clinical care. That's what we try all to do. That's why you're all here. That's why I applaud you guys for being what you are. That's why I'm here, to show my appreciation for the work you put out. It's when you come and you say to me, "Gee, doc, you know, the kid's finger was doing this," and I remember you told me that, you know, they can have a seizure. I didn't know. I didn't know it rang a bell. You know what? That's it. That's the diagnosis. I can do the EEG, and it may or may not be positive. Often, it will be negative, even in the face of a child with a seizure disorder. They have to watch them for days sometimes to do it. Sometimes they have to do photic stim, and all of a sudden, sometimes they can't reproduce it, and the child goes home to have another seizure and a worsened problem. But if you were to tell me that, oof, you know, this kid needs to see the pediatric neurologist, and we need not just an EEG, but a video EEG. We've got to have a very high index of suspicion of this kid's having a seizure disorder. And then, so what if he's seizing? Well, what was his blood sugar when he was seizing? Okay, was he hypoxic? Was he seizing? More importantly, was he seizing because he has meningitis that we haven't figured out yet? Well, if I had taken the history and mom was group B strep positive and she delivered at 34 weeks and her membranes were ruptured for a prolonged period of time and she had a fever, and then you told me that, boom, even if the kid didn't have a fever, if you saw a seizure and I even got the whiff of an infection, the child would need a spinal tap. And the time between the diagnosis and the administration of the antibiotics is the difference between a kid who turns out to be viable and productive in life versus a kid who's not. It's big stuff. Now, this is the algorithm. It's not too heavy duty. It talks about patient presents with an ALTE. Stable cardiopulmonary status, yes or no? Let's say it's no. Well, you guys live in the no. I mean, no is where you are. No is assess the airway, resuscitate patient, consider serious pathology, and then bring them in for the proper evaluation. I'm not going to dwell on that because you guys know how to support airway breathing and circulation and know how to do the resuscitation. It's stable, yes, and most of the ALTEs are. Was there apnea? Was there color change? Was there muscle tone change? Was there choking or gagging? Yes. Risk factors for ALTE present. Premature, less than 37 weeks, greater than 1 in the last 24 hours, or multiple ALTEs, suspected non-accidental trauma, okay, suspected seizures, or comorbid conditions. If the child has just been discharged from CHOP after a ventricular shunt was placed in his head to his peritoneum because he's got hydrocephalus and now he's had an ALTE, certainly you're going to look at him a lot differently than the other kid who doesn't have that kind of history. So the risk factors were there, yes, target it, test it, based on physical, admit for treatment and observation. They found by admitting and watching that even if the initial workup is negative, that it often manifests itself and helps you direct your further testing. If the history is unclear, you see what the default is? Boom, stick them in. History unclear. That's a big deal. Because that means at my hospital, if I want to stick him in and I can't get someone to take him up on the floor, he gets transferred. So a mom comes in with a kid who spit up and got limp and color changed. Wow, we're going to transfer him. Mom, is that really necessary? Well, yeah, it really kind of is, especially if these things are present. Your index of suspicion is high. So that's why these historical points are important to keep in mind. No, perform, let's say the patient looks stable and the risk factors for ALTE aren't there. Perform a physical exam, observe in the ER. How long do you observe in the ER? Nobody knows. perform targeted testing if the physical exam points there or the history points there, and consider admission. So this is stuff that after the patients got there. So that's pretty much all I had to say. And I guess we're about 36 minutes into it. Looks like that. Yeah. Do you guys have any questions at all?